Afternoon, everyone. I am honored to introduce today's first Grand Round speaker, Dr. Lena Wong. Dr. Wong is currently a second-year fellow in infectious disease at Jackson Memorial Hospital in the University of Miami. She attended medical school at Temple University in Philadelphia and completed training in medicine and pediatrics here at Jackson. She further pursued a fellowship in global health at the University of California, San Francisco, when she split her time between the Navajo Nation and far west Nepal. While in fellowship, she completed a master's in public health at the University of California, Berkeley. Dr. Wong has an extensive history of community and public service and has contributed to the Academy through 12 poster presentations and published journal articles. Dr. Wong's book chapter called Can HIV Be Prevented with Medicines can be found in the volume titled 50 Studies Every Global Health Provider Should Know, which is in circulation through Oxford University Press. After fellowship, Dr. Wong plans to return to work in the Navajo Nation. It is my distinct pleasure to welcome Dr. Wong to Internal Medicine Grand Rounds.
Hi, good afternoon. My name is Lena. I'm finishing up fellowship in the next couple of weeks, but I want to talk about my time in the Navajo Nation, which I spent just about 6 years working in that area. So my presentation is entitled Disharmony on the Navajo Nation. So the objectives of today, first thing is I'm going to talk about the key clinical symptoms and diagnostics of hantavirus pulmonary syndrome, but then also I want to describe the unique challenges facing the health of Native Americans, and then we're going to talk about actionable items to establish health equity for Native Americans. So I'm going to start off with a clinical case because I think it's actually probably the best way to describe this syndrome. So this is a case I saw in my first year out working in Tuba City, Arizona. So this was an 18-year-old healthy female that came in with about a week of headache and fever, nonspecific viral symptoms, but then developed 1 day of vomiting, abdominal pain, and shortness of breath. She's from an area in the middle of the reservation called Tonalea, Arizona, and had no notable contacts. She works at a restaurant, stays home with her family. Was a kind of regular 18-year-old. So she came in, vitals significant. She's febrile, tachycardic, tachypnic, and hypoxic. And then notable labs, she did have a white count with a bit of a left shift, hemoconcentration, and then platelets of 65,000 with a chest x-ray with bilateral diffuse interstitial edema. In our emergency department, she received supplemental oxygen, but was rapidly progressing with increasing respiratory distress, and she was intubated. She was transferred to the University of New Mexico, which we usually transfer when we suspect hantavirus syndrome via air flight for further treatment. She was later found to have positive serum hantavirus IgM, which is also known as sin nombre, and she required ECMO, but unfortunately she had numerous episodes of cardiac arrest and was unable to be resuscitated. So hantavirus is a rare entity in the United States, but there is 2 types generally. In the Western Hemisphere, it largely causes pulmonary syndrome, but in the other parts of the world, in Europe and Asia, it causes hemorrhagic fever with renal syndrome. So this is just a further map describing kind of where these different strains are found and in what quantities, but it is a global zoonotic challenge across the world. This is from the Centers for Disease Control infographic on hantavirus. The key things you want to know, this is since 1993, but there's been 850 cases. The race of confirmed cases, for however you take that, is 70% American Indian or Alaska Natives, which is notable compared to the national percentage of Native Americans, and then notable for a very much younger median age of confirmed cases, which is on median with 38, but the range was 5 to 88. And then this other number that's very significant is the case for fatality rate, which at the time of this was 35%. So in the United States, this is largely where it's been distributed, and in the 4 corners region of Arizona, New Mexico, Colorado, and Utah, there is a significant amount of cases given the population of these states. But then you also note that Florida did have 3 cases of confirmed hantavirus disease. This is specific to the Navajo Nation. So we'll talk about this surge here in 1993, where there are 19 cases that were found. And then over the next number of years what the cases have been looking like. And this is from the Navajo Epidemiology Center. However, in April of 2023, they did send out a public health advisory where they have found 4 cases of hantavirus already this year confirmed in the Navajo Nation within New Mexico and Arizona specifically. So the 1993 series of cases was when the United States largely was recognizing hantavirus as an etiology, but however, if you talk to Navajo elders, Navajos tend to have oral traditions with their history passed down along stories and song. And they did notice that there were cases of rapid onset lethal diseases in 1918 and 1933. And they reported this as disharmony, where there was an excess of, which was an excess. So there was excess rains in all these years, and then that led to a bumper crop of piña nuts, which led to a boom in the rodent population. And this disease is largely spread through the aerosolization of rodent excreta, saliva, and urine. The diagnosis of this is, because of its relative rarity, is difficult. And then, but there are a few kind of key factors that we notice. The incubation period is 1 to 8 weeks. Because of this prolonged incubation period, however, a lot of people will be unaware of their exposures and maybe will not point to a certain point in time where they might have seen this. You start with this prodrome about 4 to 10 days, and then you develop the cardiopulmonary symptoms after that, the average of that being 5 days. However, after you develop the cardiopulmonary symptoms, there's rapid progression, and within 1 to 2 days, severe respiratory failure can develop. Laboratory-wise, thrombocytopenia is the most consistent finding, and oftentimes, if you're unsure of the diagnosis, you can trend a CBC and you'll notice the rapid decrease in platelets over 8 to 12 hours. For as far as more specific testing, there are serological assays. So you can get serum blood samples to detect IgM, or you'll notice a detection of rising titers of IgG. For us in Arizona, the Arizona State Lab does it, as well as some of the other hospitals. The New Mexico lab also does it, and along with the University of New Mexico and a lot of the medical centers in Arizona and New Mexico and Utah will do these. There are antigen and PCRs available, but these are largely available through the CDC, and the samples would have to be sent through them. So with a disease that's very difficult to diagnose and with specific testing that may not be rapidly available, this is a study at the University of New Mexico where they successfully triaged suspected hantavirus using peripheral blood smears. So they used 5 criteria, which included hemoconcentration, a left shift, toxic changes, which were defined by toxic granulation, the presence of Dolly bodies with variable vascularization of majority neutrophils, thrombocytopenia, and the presence of immunoblasts. And then you could see on their table 1 what the sensitivity, specificity, and predictive values were. And then if you hit all the criteria, you can see this positive predictive value of about 100% and a negative predictive value of about 79%. And with a bit of a variability throughout these, depending on how many criteria you have. So for us who don't often look at slides, on the left-hand side, this was an example of fulminant hantavirus infection and the presence of an immunoblast. And then on the right-hand side, this would be the toxic changes. So boxes A and C are the normal findings you would have. And then in B and D, these are the toxic changes where you have more condensed chromatin and bluer findings on the staining. So with this, there were a few follow-up studies. The first study was this successful implementation of a rapid screening tool for hantavirus in a community hospital and endemic region. So this was in Sohotso Medical Center, which is in Fort Defiance, Arizona, and in part of the reservation. And there they trained their lab personnel, which weren't pathologists, to look for these toxic changes in a peripheral smear. And they were able to correlate a lot of the UNM findings in their small hospital. That hospital has probably about 40 beds and it's not a large hospital by any means, but it is an endemic area where they see a lot of these, they can potentially see these cases. And then another follow-up study was that they tested these 5-point screens in COVID-19 patients, because the presentation can be very similar, and they found that the screen was still predictive of hantavirus disease within this time frame of the COVID-19 pandemic. This is the CDC case definition. We do not use this as a diagnostic definition because on it, part of the case definition is related to healthcare records and death certificates. But this is when the CDC reports their epidemiological data. This is how the cases have been defined by the CDC. So for treatment, unfortunately, it's largely supportive care. There are no FDA-approved treatments. Supportive care includes just general critical care management, but many patients have been requiring ECMO. The studies that so far in humans that have not been found to be effective were ribavirin and steroids, such as methylprednisolone. And there are some animal trials that have shown some success, notably with favipiravir, lactoferrin, monoclonal antibodies, but no human studies have shown these same findings. Prevention would largely be the most important measure. So one would be rodent control, but then also when families are cleaning out their sheds or basements or areas that might have these rodent excreta, ventilation would be very important, and as well as masking and gloving. And we often tell patients to throw bleach on these areas before you start to clean up so it doesn't aerosolize and many of these things. So as far as vaccine development, there is a Hantavax vaccine, but that is for the hemorrhagic fever and renal syndrome, which is protective against the Hantan and Seoul variants in Asia. But this has not been effective against European variants of HFRS or the US variants that cause hantavirus pulmonary syndrome. Unfortunately, there's probably not a whole lot of other vaccines that are far and left along in trials to discuss right now. So shifting a little bit, that's kind of the gist about hantavirus, but I want to talk about Native American and especially my experience in the Navajo Nation. So not a population we see as often here on the East Coast. So this is a map of the number of tribes in the United States, where large concentration in Alaska and in the West Coast, but in the Eastern region, there's 34 established tribes in this area. And then in Florida, this is Southern Florida, the local tribes that we have recognized here are the Miccosukee, the Seminole, and then these are the reservations of Big Cypress, Miccosukee, and Brighton. This is where I was practicing before, and that's the Navajo reservation with the Hopi reservation within the Navajo, and then surrounding, but we do have some patients that come from there's Southern Ute and Zuni as well. So describing what a tribe and reservation are, so they're nations within nations. These are sovereign tribal nations. There's 574 of them and 334 have federally state recognized reservations as of 2010, which is always a number in flux bit in 35 states across the United States. So sovereign nations have the right to form their own governments. They determine membership or citizenship, they enforce their own laws, they regulate trade, and they act as nations within nations. Sovereignty is the internationally recognized right for a nation to govern themselves. And all these tribes existed long before Europeans settled in the United States and the Americas. So important historical periods in this time frame. Some definitions, tribal, this is pre-contact period, was the time up to 1492. Then we went into colonization period. The treaty periods is when a lot of these government treaties for the Indian Health Service and for the Bureau of Education were all established, and the reservation system was established. But then they went, depending on the federal government and who's currently in charge of the federal government, they underwent a removal period, but then it underwent an assimilation period, tribal reorganization, and then self-determination. So some of these terms, tribal reorganization was reverse cultural assimilation, meaning that the tribes gain back some of their sovereignty. Then termination, they just go in these phases where their rights are constantly being in question and in flux. And then largely in the self-determination phase as of now, and that was started in Nixon's presidency. So the treaties established that Native Americans were able to receive healthcare from the federal government. However, the Native Americans do feel slightly invisible in this US healthcare system, that they feel largely forgotten, especially this was prior to the pandemic, but the pandemic brought a lot more of these situations to the surface. And they felt that the resources and the discussions about the COVID-19 pandemic weren't involving them as much as it could be, especially when many nations were having higher incidence of COVID-19 infection compared to the rest of the country. So I'm going to talk about some of the inequities and inequalities that I've seen there. So one of them is just starting as basic as you can with data and census and how many people that the federal government is recognizing and how do they count these people. So during coronavirus, but even prior to this, Native Americans were being left out because they were being considered as others, and as well as they combined all Native Americans into one large entity where Alaska Natives and Navajos and Seminoles might have different health disparities based on different parts of the United States they're living in. And largely, the tribes are calling for sovereignty over their own data to help their own people. Another concern with providing access to care in the Navajo Nation. So this is a map of the Navajo Nation. It's a landmass the size of West Virginia. So I was in the far west side, which is Tuba City, but these are a lot of pretty spread out areas where there's healthcare centers that aren't as frequently distributed. So for transportation for some of our patients, even within our service unit to get to our hospital can take up to a couple hours. And part of that is there may not be paved roads to some of their homes. So getting ambulances out there, and then also for them to provide their own transportation and gas coverage to get to our health center is very far. And in a arid area where there's no paved roads and it rains, then their roads might be washed out, or there's too muddy to get to a healthcare center. And then by the time they get to our center, which is most of these IHS hospitals in our area are pretty small. So if they need a higher level of care, our next closest major center would be in Flagstaff, and that takes an hour and a half by car or a 45-minute flight to get to transfer these patients. And then during COVID, patients were being transported as far as Tucson or Phoenix, which is about 5 hours away, or a couple hours by helicopter. And this is all within the setting of limited ambulances and limited helicopters as well. So if you have a helicopter that's going for hours a day, there's a limited amount of patients they can transport in that time. The other issue with rehab and skilled nursing facilities, there are also extremely limited on the reservation. So when patients have to go off the reservation for these kinds of services, they are very far from family and friends. This is some data from 2020. This was specific to the Navajo Nation. So there are 30% of households that don't have running water in the Navajo Nation, and then about the same that are without electricity, and those two go hand in hand. You need electricity to pump water. And then in the area, the Navajo Nation with this size, there are 13 proper grocery stores. And then for comparison, in the same setting, or in the same landmass size, there are 162 supermarkets in West Virginia. So what can we do about these situations? So a few actionable items. The first one is to become more educated on Native American health. So there's a number of medical organizations that you can find more information. So one is through the AAP, the American Academy of Pediatrics, which has a lot of resources on the Native American child health, or the Center for Indigenous Health through the Johns Hopkins Hospital. And there is a number of education and trainings, and they describe the research they've been doing across the country. Otherwise, in just popular media, Reservation Dogs, Basketball Nothing, a couple of TV shows that show kind of life up for teenagers on the reservations. Project 562 is a photo journal of different ways we can view Native Americans and changing the historical way we've seen them. There the Miccosukee are the closest, probably closest tribe between there and Seminole, and they do have arts and crafts festivals. There is an education center in the Miccosukee Reservation. You can take airboat tours, but it is a place where they can tell you the history of living in the Everglades and what they experience in this country. And then numbers and numbers of books written by Native American authors, both fiction and nonfiction, regarding the experience in the United States and then the history of the United States for Native Americans. Following this, the one thing that kind of everyone could do for some of these patients would be advocacy. And this is one of the resources I've used, which is the National Congress of American Indians, where they provide news and updates about current issues in Native America, and then what you can use for communicating with the US Congress and local officials about legislation affecting these patients out there. A couple ones that are currently up for and examples of what how legislation affects the Native Americans. So one case is the Arizona versus the Navajo Nation for the fight for Colorado River water rights. The West Coast is largely dependent on the Colorado River for water supply, and it's been drying up over the past few years. And especially in a resource limited setting already, the Native Americans and the Navajos out there are fighting to continue to get their piece of the Colorado River. And then the Supreme Court is about to rule on the Indian Child Welfare Act, which was historically that many Native American children were being removed from their families into foster and adoptive care. And this act was passed to help retain Native children with Native families, and it's being revised by the Supreme Court, or reviewed by the Supreme Court at this time. Also, this is the healthcare spending for IHS compared to, on the furthest left is the national healthcare expenditures per capita. And then you could see that the IHS receives less money per capita compared to the Veterans Health Association, Medicaid, and Medicare. And following this, these are the list or map of IHS facilities, largely concentrated in the West Coast. But you could see that this is the healthcare professions vacancies by rate. So there are some that are better staffed than others, but there are places where medical officers vacancy rates are up to 60%, nurse vacancy rates are up to 60% as well. So definitely a need for healthcare professionals to get to these areas, as well as to help train local staff and community members to help fill these positions as well. So key takeaway points that I'd like you to have. First one is about hantavirus. It should be suspected in young, healthy patients from the Southwest United States in an endemic region with rapid respiratory failure and thrombocytopenia. Secondly, Native Americans remain an underserved community with significant barriers to health, and actionable items include education, advocacy, and strengthening our local workforce. With that, I think anybody has any questions? We have a little bit of time.
Thank you, Dr. Wong, for that very enlightening lecture. We appreciate it very much. A couple of questions I have. First, what are you going to do next year if you're finishing your fellowship in a couple of months?
So I will be returning to the Navajo Nation, and especially Tuba City, to do medicine, pediatrics, and infectious disease, as well as public health.
Wonderful. So to follow up on that, you mentioned about vaccination. And although there aren't vaccines available yet for the European or American version of hantavirus, I imagine globally this is an important thing, and probably vaccines are going to be developed. What is the likelihood, though, of the Native American population accepting vaccinations if there were to be one for hantavirus?
So I think based on local epidemiology, it's still a relatively rare disease, but based on our COVID-19 numbers, Native Americans actually had one of the highest uptakes of COVID-19 vaccine. And that's largely because the morbidity and mortality from that has disproportionately affected them as well. So very high rates of acceptance for that newest vaccine. So I expect it would be high if it was reasonable to offer to.
If anyone has any questions, please unmute yourself. I see lots of congratulatory and laudatory comments in the chat. Please, Dr. Wong, to look at them when you have a chance. You've obviously made a very big impact during your tenure here as a fellow, and we're grateful that you were here. Thank you. Okay, Dr. McBride, why don't we introduce the next speaker?
All right. It is an honor to introduce our second grand round speaker, Dr. Frank Cusimano. Dr. Cusimano is a DO PhD, finishing up his second year as a resident in internal medicine here at the University of Miami and Jackson Health System. He graduated from medical school at the Arizona College of Osteopathic Medicine and earned his PhD, MPhil, and MA in nutritional and metabolic biology from Columbia University in New York City, where he defended his doctorate thesis titled Engineered Bacteria for the Modulation of Intestinal Physiology, Inflammation, and Behavior along the Microbiome Gut-Brain Axis. Prior to medical school, he attended Johns Hopkins University and completed a Master of Science in Biotechnology, concentrating in bioinformatics. Dr. Cusimano has published over 18 journal articles and abstracts. He has 6 first author journal publications. Outside of medicine, Dr. Cusimano was formerly a professional cyclist for DNA Racing and has co-exhibits displayed in the Guggenheim Museum in New York City and La Biennale di Venezia in Italy. Dr. Cusimano plans to pursue a career in academic medicine and is applying to fellowship in gastroenterology this fall. It is my distinct pleasure to introduce our very own Dr. Cusimano to Internal Medicine Grand Rounds.
Thank you, Andrew. Dr. Wong, I also wanted to say congratulations on a great talk. Back in the day, I'm actually part Cherokee. Back in the day, I used to be a Native American grass dancer. I don't know if you could see the image on my phone, but I used to dance back in the day at powwows. So I guess I'll go ahead and get dived in with that. Okay, so probiotics in clinical practice. So here are my objectives. I think it's fitting that we have this presentation on June 14th. As of just about 2 weeks away is June 27th, which is referred to as World Microbiome Day. So I think that's pretty interesting. In the advent of the Human Microbiome Project in 2008, we have increasingly become aware of the role that bacteria play in the development and homeostasis of humans. Now, the human body is home to be about 1 to 10 times as many microbial cells as human cells, and each of you lay home to a diverse population of between 300 to 1,000 microbial species with a collective genome of about 150 times that of your own. Now, while there is a unique microbiome on each surface of our body, we'll be focusing on the gut, but at a very broad level, it's linked to multiple diseases, many that are still up for debate. What most do agree on is that microbes in our intestines play a fundamental role in immune function, metabolism, barrier protection, nutrient utilization, inflammation, and infection. Now, for the past 15 years, scientists and clinicians have studied, tested, and iterated on ways to change the microbiome. We've tested diet, lifestyle, antibiotics, fermented foods, prebiotics, phage therapy, postbiotics, and symbiotics. And it's interesting to note that while we think of like fecal microbial transplants as new and novel, it actually was being done back in 400 AD in Eastern medicine for patients suffering diarrheal illnesses. They called it yellow soup. Thankfully, we don't use it anymore. However, we will mainly be focusing on probiotics. So clinical vignette, a 38-year-old female with a past medical history of hypertension presented to an outpatient clinic with unusual vaginal discharge, pain with urination, and pain during sex. She reports no prior history. She had vaginal intercourse with a new partner recently without protection. She refused the GU exam, stating that she had an appointment with her gynecologist next week, but agrees to STI testing. Now, urine was positive for chlamydia. She was prescribed doxycycline, but was very hesitant initially to the antibiotics. She agrees eventually, but asks if she should go out and buy probiotics and if this is the safest antibiotic for her gut health. So what do you do next? Do you advise the patient to take any probiotic over the market for the next 7 days with the antibiotic, switch from doxycycline to azithromycin, encourage a healthy lifestyle and prebiotic foods, or advise her to take a probiotic specifically with Lactobacillus rhamnosus GG at about 10 billion CFU? All right, so what are probiotics? Probiotics are defined as microorganisms that, when administered, provide at an adequate amount, confer a health benefit to the host. Now, the global market for probiotics is valued at about 58 billion back in 2017, but it's estimated to get to 131 billion by 2032. an interesting survey that came out in 2010, a little outdated, but still interesting, that 98% of gastroenterologists felt that probiotics played a role in GI diseases. They had about 93% of the gastroenterologists had patients taking probiotics, but they didn't believe that their practice was necessarily supported by scientific data. 13 years later, it'd be interesting to repeat this study to try to see what, kind of where this falls, knowing what we now know. So a little bit of anatomy review. Obviously, you guys understand the gastrointestinal tract all the way from the stomach to the anus, but the concentration of bacteria varies. Higher up in the stomach, we actually have only about 10 to the 2 CFU, whereas when you get all the way down to the colon, that's where you get a much higher concentration of bacteria in the gut, and it's between about 10 billion all the way to about 1 trillion bacteria per ml. This isn't going to be a microbiology lecture, so I'm not going to go into talking about all the nomenclature of bacteria. The graph on the right may provide you some hesitance back to your biology days, but just interesting to know that when you're talking about probiotics, it's really the strain level specification that matters. Even discussing different, the same species doesn't necessarily matter. If we think about things like Bacillus coagulans, which is a common probiotic, they have found that there's as much as 95% differences in the genome between 2 different strains of that same species. So species level discussions are pretty much irrelevant when it comes to microbiome or probiotics. So when I think about probiotics, I like to think about a graph, and one is efficacy and one is viability of the probiotic. And on the x-axis, we have efficacy, and on the y-axis, viability. Most over-the-counter probiotics you're going to find are going to be farther down on the left, where that red circle is. But we want to get to the area where it's up in the green, really where we're with a totally different approach that we're not necessarily taking right now. So on the x-axis, what does efficacy mean? It's anywhere between the probiotic being ineffective completely, all the way to precise, meaning it does a specific function that we want it to do. And when we think about viability on the y-axis, I like to think about probiotics anywhere being non-viable, meaning they just go straight through your system and don't do anything, all the way to where they actually colonize and perform a function. So here's some of the common probiotics that you may see on the market. These are placed in here, and you can see that most of them, some of them can have some targeted features, and some of them have some prevention features, but none of them get up to where we really want them to. That one that's higher up, E. coli Nissl 1917, is not something that we have available here in the US. It's approved, I believe, in Canada and definitely Europe, but we don't have it available here in the US for consumption. So dosing of probiotics. So we always think of CFU. I'm sure you guys remember that term. Most probiotics are between 1 billion and 100 billion CFU, and the concentration really matters depending on the given strain. That number on the bottle should be listed as the expiration or the use by date, but some manufacturers are now putting at the time of manufacture, which should be avoided. You want to know what concentration you're taking when you take it, and that it lives throughout that expiration date. There's also some that are now using AFU or TFU. Those are active fluorescent units or total fluorescent units for bacteria that are not culturable, and that is actually measured through cytometry. So formulations for probiotics. Is a multi-strain probiotic better than a single strain probiotic? In the past, we had always thought that there was a difference, but there really is no difference. It really depends on what's been tested. So for example, if you have a combination 8 individual strains that are brought into one packaged probiotic and then delivered, unless that specific formulation has been tested, you can't really trust individual results. So you can't take 8 individual probiotics, find their effect, combine them together, and then hope for 8 effects when you give them all together. Bacteria interact with each other and they affect each other. So everything that has to be given has to be tested in that same formulation. Obviously, the GI tract is a harsh environment. When you take a pill, when you take a supplement, when you take anything, it has to go through a whole host of things in competition to get to where it needs to go. So in the upper GI tract, we have a very acidic environment. We have enzymes. Farther down, we have the bile salts. We have immune cells that clear some of these bacteria. There's nutrient competition. There's space competition. The bacteria need to get near the mucosal layer to have any effect on the host. And then there's also the effect of, as you get lower down, there's less oxygen. There is a gradient. Oxygen is higher along the epithelial cells and more anaerobic in the interlumen. But you also have constant movement with the peristalsis and epithelial turnover and the sloughing of the mucosa. So previously it was thought that the liquid-based probiotics were better than those lyophilized pill probiotics. This is not necessarily the case. There's a whole industry that's focused on trying to design the best formulation and encapsulation technology. So now they're using living hydrogels, they're trying different adhesion molecules, they're trying double-coated capsules, one that gets through the stomach and the small intestine. But it's interesting to see that you have these combination therapies that are being used. And if you look at the different, the single pill versus the double coated versus the matrix versus the hydrogels, as it goes farther down to the GI tract, it starts to release and break down some of these probiotics. Not every company and manufacturer is using these. These is kind of where the industry is on a research level trying to get there. So what are the clinical applications of probiotics, right? So about 5 years ago when I gave a different lecture, we were looking at this, we found that most of the guidelines had focused on genus and species level recommendations. They gave a probiotic and they said these may be effective for X, Y, and Z. But as you can see here on the left, these are out, this is kind of old data, and you saw nothing that gave absolute recommendation for any of them. Nowadays, we actually got lucky that in 2020, the American Gastroenterology Association published guidelines on gastrointestinal disorders and the role of probiotics in them. And so that's what most people go by. I'm going to use these guidelines first to go through, and then we'll go through some other ones for some other organizations. So one, for patients with C. diff, there's actually a very clear recommendation that probiotics should only be used in C. diff in the setting of a clinical trial. There's not a good enough data to use them during active infection. For patients, adults and children on antibiotic treatment, probiotics have a conditional recommendation with low quality evidence for patients that you suspect may have a higher risk of C. diff. So you're taking these probiotics to prevent C. diff infection. So on the right-hand side, you see the 5 different risk factors for C. diff: antibiotic exposure, older age, weakened immune system, previous history of C. diff, and recent stay at a hospital. So those are really where you may want to tailor the antibiotic use for, but it's also very reasonable to select no probiotics as mentioned in the comment under these recommendations. What about patients with inflammatory bowel disease, Crohn's, ulcerative colitis? Probiotics are only recommended in the context of a clinical trial. There's no data to support them for active infection or for prevention. What about pouchitis? So for adults and children with pouchitis, there's an 8-strain combination that may be beneficial over no probiotics. Again, it's a conditional recommendation with low quality evidence, and they recommend this, but they say if there's any issues with cost or feasibility of getting that 8-strain combination, that you should actually just give no probiotic instead. So what about patients with irritable bowel syndrome, both adults and children? Probiotics should only be used in the context of a clinical trial. And for children with acute infectious gastroenteritis, it's actually a conditional recommendation with moderate quality evidence that probiotics should not be used. So they suggest against the use of probiotics, and maybe that changed over the years, but that's actually has moderate quality evidence. And then probably our strongest evidence that we have here, the last guideline that they have, is for preterm and low birth weight infants. Anyone that you're worried for the prevention of necrotizing enterocolitis, there's a conditional recommendation with moderate to high quality evidence that probiotics may be beneficial. Again, probiotics being the strains that they have listed up there on the left, there's different combinations in multiple different ones. I'm not going to go through them, but if you treat children or preterm birth or low weight birth into infants, these may be recommended. What about those other guidelines? So the World Gastroenterology Organization published a new guideline form in just February of this year. They're a little bit more of a liberal approach than the AGA, and they cover a few additional diseases that are not just GI. And then also I like to use occasionally Cochrane. Obviously they don't produce guideline statements. Some people have issues with some of their systematic reviews, but for overall, they provide pretty good evidence for the more recent literature, and they are updated a lot more frequently than some of these guideline statements. So what are these other illnesses? Things like diabetes, dyslipidemia, obesity, and constipation. There's really no high quality evidence. There's only low quality evidence, and there's no clear consensus of if you should use probiotics in these instances. For H. pylori, there's no evidence to use probiotics alone without concomitant antibiotic therapy. And this is actually an interesting one. The second one on the list up there, prevention of gestational diabetes. This is from a Cochrane from 2021 that came out that said there's actually high certainty evidence that probiotics actually increase the risk of preeclampsia. So I think that's pretty interesting and not something that we routinely talk about. For those individuals, you should recommend against probiotic use. What about the other ones? There's radiation-induced diarrhea. So there's about 4 meta-analysis that all are pretty consistent, showing a benefit for prevention and treatment of radiation-induced diarrhea. I could see a guideline statement coming out about this in the future. It's not quite there yet, and they haven't measured the quality of the evidence. And then what about pediatric antibiotic-associated diarrhea? The Cochrane review found that there's moderate quality evidence suggesting that there may be a protective effect in preventing that diarrhea, but only with Lactobacillus rhamnosus GG and Saccharomyces boulardii, but it should be avoided in immunocompromised patients. And then the third one on the list, which is the last real disease, is from a Cochrane review that came out in 2022. There's low certainty evidence, but it's actually interesting. And this has actually been confirmed from previous Cochrane reviews from I think 2015 and 2017 that showed that probiotics may be beneficial in preventing acute upper respiratory tract infections. Again, low certainty evidence. It's not something that I use in practice. I don't think it's something that most people use in practice, but it's interesting to note that they may prevent acute URIs. And there's not enough evidence for everything that's listed below. And also you can start to think about the fact that most things you see on social media or online today, there's probably low quality evidence, or they're basing any recommendations off of like a single study or a single review, which we should try to avoid, especially in probiotic research. And why is probiotic research so terrible? Well, most microbiome research has a lot of flaws. The research is pretty poor, and that's because not all researchers are using the same standards of normalizing the data or accounting for sequencing biases when the microbiome's tested. Good research requires strain level specificity of the probiotic. It requires the same formulation, the same delivery mechanism, the same concentration, but also the participant themselves. What really matters is what their diet is, what their native microbiome is, and what they've been eating over an extended period of time before. We'll talk about a little bit about it later, but it really matters what that native microbiome is and the individual of someone that's going to have a response to a probiotic and someone that's not. So here's some fast facts that I'm sure you guys will get questions about in the clinic, or you get questions about before, and that's, do probiotics just go straight through me, or do they colonize? Well, we used to think most of them just went straight through us. They weren't colonizing bacteria. But an interesting article that came out from Aaron Segal's lab in Israel actually showed that there's 2 different phenotypes of individuals. Some have probiotics that colonize, and some have probiotics that do not colonize at all, and they just go straight through. And there's predictive patterns when you look at the microbiome of which ones will colonize and which ones will not. It's not something we have commercially available. You can't send a patient to go get tested to know if they're going to colonize probiotics or not. But it's something interesting to think about that maybe it's in the future we can think about. And do probiotics actually help repopulate the gut after antibiotics? Well, there's actually this same group, Aaron Segal's lab, came out with a paper in that same year as the first one that showed that probiotics actually delay regrowth of the native healthy bacteria of individuals after antibiotics. So I like to think about, like, I used to live in Arizona, so I like to think about this from like a flooding standpoint. When there's a huge flood, the water washes away all the native vegetation, and it takes a while for the native vegetation to grow back. That water rushing in is kind of like an antibiotic, killing everything as it goes by. And then that the native plants are like your native microbiome. It takes a while for them to grow. They have to get some of the water, some of the nutrients. They have to regrow and build to be healthy. If you came and then threw in a bunch of random plants to try to make the area look better, there's going to be a competition of resources. They're going to outcompete the native plants, and that's exactly what happens with the gut. So sometimes probiotics may not be beneficial. Instead, you should recommend high fiber foods and a healthy variety of fruits and vegetables. And that brings me to prebiotic foods, right? Some of them are listed above. Prebiotics actually will help the gut most, especially after antibiotics. You could think about prebiotic supplements, but prebiotic supplements have only been shown to provide additional benefit when a participant actually already consumes a high fiber or high variable fruit and vegetable diet. What about probiotics? Should they be on the shelf or the fridge, and does it matter? You should really listen to what the manufacturer says. Some are kept in the fridge on purpose. because they've been shown that's where their efficacy is, and some that are lyophilized bacteria can be kept on the shelf with no issue. But temperature does matter, and here's why. Is like when I used to live in Arizona, we had delivery trucks that would routinely get over 40 degrees Celsius. We find in the literature that after 40 degrees Celsius, any probiotic that has hit that temperature decreases in efficacy drastically. So even some of those lyophilized pills, if they were shipped in delivery trucks that reached up to 40 degrees Celsius, their efficacy is going to drop significantly. So in hotter environments, sometimes those fridge probiotics are a little bit better because you can ensure that they've been transported under refrigeration. What about, do probiotics increase short chain fatty acids? Well, we're going to talk later. The last part of the presentation is about secondary metabolites. Probiotics and bacteria in our gut produce these secondary compounds. We normally think of short chain fatty acids like butyrate, acetate, propionate, but they also can produce things like neurotransmitters, secondary hormones. Some probiotics produce these compounds and some do not. It really depends what's been tested in their given genome. So it's not a blanket statement that all probiotics will help with these. It really depends on the specific strain that's in that probiotic. Going back to our clinical vignette. So in this instance, you would have actually picked C, encourage just a healthy lifestyle and prebiotic foods. And that makes sense because this individual is not at risk of developing C. diff, and she's not at risk of any of the other things that we discussed. In terms of the probiotic, would you change probiotic? There are antibiotics that you can kind of risk stratify in causing diarrheal illnesses. We normally don't make our clinical decisions based off of what the risk is of causing diarrhea by an antibiotic, and I don't recommend anyone does. But it's interesting to note that kind of if you have a patient that comes with diarrhea that's been on an antibiotic, you can kind of see what their risk is of it being from the antibiotic. So earlier I talked about this graph. I inputted here some of the common over-the-counter probiotics, but we want to get up to this top area, the living bacterial therapeutics, where I'm going to spend the last few minutes talking about. And this is some of my thesis work, and it's in the idea that we get to this advanced bacterial therapeutics. It's using synthetic biology to design bacteria to perform a function. So what is synthetic biology? Well, synthetic biology is an interesting field that mixes biotechnology, genetic engineering, molecular biology, and electrical and chemical engineering to produce bacteria that perform a function. Think about the probiotic or the bacteria as a biological machine. It's almost like a drug therapeutic delivery system at a very localized area that it can produce a specific compound that you want. So some of my thesis work is we came up with the idea of, could we get specific bacteria to be genetically engineered, produce a specific compound or molecule to then go and perform a function in the specific part of a GI tract of an animal or of a human. So we took that Nissel 1917 that I showed you earlier, we engineered it to produce secondary compounds, multiple different ones. And in this example, you can see that we wanted to get it in the enteric nerve, or get it in the colon near the enteric nervous system to produce serotonin. And then we can go, after repeated administration, measure different things in the GI tract and measure behavioral changes to try to see if interluminal serotonin played a role on any of the pathology or the physiology. So to produce serotonin, you have to think of the starting molecule, which is tryptophan. And then from there, you can see the two enzymes, TPH and TDC, to produce serotonin here on the top. And then the byproduct of tryptophan to serotonin is actually this tryptamine, which also is a different neurotransmitter that we don't normally think about. And so what we use is CRISPR technology and microarray analysis to find what is the best combination of genes from different species out there to produce the highest amounts of serotonin in vivo. So here we had 3 different strains. We had our control strain, our ON9 here in the middle, the gray strain. We have the orange strain that produced only tryptamine. Unfortunately, when you're going to produce serotonin, you have that tryptamine as a byproduct that you can't really avoid. So we did produce a strain that only produced tryptamine because that allowed us to use that kind of as a negative control or a positive control. And then we had ON14 that produced both serotonin and tryptophan. And if you look on the right, you can see the graph of the concentrations that we were producing we have both in vitro and in vivo concentrations measured, but in here we just have the in vivo ones. So then what was our experimental design? We first equilibrated the gut microbiome of the animals. We fed them for 10 days, these probiotics, And then at day 11, we were able to look at things like gene expression, GI transit, the microbiome, behavior, histology, and went ahead and looked at some of them. So how do these actually colonize? Well, I talked about colonization a little bit earlier. If you look at the top, you can see from stomach all the way to distant colon, you can take bacterial samples and try to see what the concentration of these. And in the proximal colon, which is what these images are from, and then the graph on the left, you see that we got fairly high concentrations, between 7 to 9 log CFU. And then on the right, we use a immunohistochemistry. We use an antibody specifically to the strain that we developed. And you can see that the engineered strains lived right at the mucosal layer along in, and then you see that in red. That's right up against the epithelial cells in the mucosal layer itself. So then how did these produce serotonin in vivo? So in the serum serotonin levels, we actually saw no difference. It didn't affect serum serotonin levels. Did it affect colonic tissue serotonin? It actually didn't. We went ahead and measured it, and that's what that middle top graph is. There's no effect in the colonic tissue serotonin. In the fecal serotonin, though, you can see about a 10 to 20-fold increase of what the native serotonin levels is through a ELISA assay, and that's over there on the top right. In serotonin, we can also use an anti-serotonin antibody to measure the immunohistochemistry. If you see the 4 images on the bottom right, you see that the things that are lighting up in green in all of the images in the epithelial cells are actually neuroendocrine tumors or neuroendocrine cells. Those cells have a TPH1 mediated pathway to produce serotonin. And then in the bottom right on the ON14, you can see in the mucosal layer, if you look closely, there is green in the mucosa, and that is that antibody is fluorescing the serotonin that's being produced by the bacteria that's in the mucosa. So when you're looking at things that serotonin affects in the gut, one of them is it affects inflammation, but also that mucosal layer. The mucosal layer is very important for gut health. And we see that the serotonin producing bacteria increase the amount of mucosa, both with real-time PCR on the left, but then also in the immunohistochemistry using an antibody against that MUC2 protein, which is the primary protein that's found in the mucosal layer. You can see that it's a little bit thicker and a little bit more pronounced on the bottom right. What about, how did it affect the genes of the GI tract, meaning the genes of the actual tissue? So earlier I mentioned that TPH1 gene, that's the rate limiting enzyme in the conversion from tryptophan to serotonin. TPH1 is found in neuroendocrine cells, and TPH2 is found in the enteric nervous system. We did see an increase in the TPH2, which is the amount of serotonin in the enteric nervous system, or that rate limiting enzyme in the enteric nervous system. And it's really interesting to what our hypothesis or what we think was happening was that the bacteria was producing serotonin. It wasn't necessarily getting absorbed, and it wasn't necessarily affecting the neuroendocrine cells, but it was affecting the enteric nervous system. And we see that with the upregulation of TPH2, maybe the native amount of serotonin that was being produced in the enteric nervous system slightly increased. And we see this with the change in GI transit. So we measured how long it takes for the feces to be produced, and we saw a decrease in the total transit of these mice, meaning that they had a delayed transit. It doesn't mean they were constipated at all. It just means there's a decrease in their total transit, and that could be from that change in serotonin that we measured earlier in the TPH2 mediated pathway. So then we also did some behavioral testing on these animals. We did both a forced swim test, but also we did testing in what's called a boxed test. Mice do not like to be in open, bright environments with an open area, and they don't like the color white. So you place a mouse in a box, in a white box with a bright light, and then you use computer software to track the movements of that mice over like a 6-minute period. Most mice will want to keep their back up against the wall. They don't want to explore the center. And this is just representative diagrams on the right of one specific animal, but we had ends of like 10 to 20 in each arm. You can see that on the bottom right, the ones who were receiving that ON14, that serotonin producing strain, had spent more time in the center of the box, meaning that they either had lower amounts of anxiety and didn't want to necessarily be up against the wall as much, or they were more exploratory and willing to move around. They also defecated less. When mice are stressed, they defecate, as you can see up here on the top left, but there is a decrease in the number of defecation or the number of bowel movements that they had during that 6-minute period. So we talked about serotonin already doing this, but you can think about this with any secondary metabolite, butyrate, acetate, any of the other compounds like GABA or dopamine. We only tested 2 of them. The second part of my thesis was focusing on how we can do this with butyrate, trying to produce butyrate at a higher concentration right up against epithelial cells with these same engineered strains. But I didn't produce any of that data here only for the sake of time. So I think the larger picture is probiotics should be used in the future. We can see these as more advanced bacterial therapeutics. Maybe they're going to be FDA approved at some point, as opposed to only being used as just like a generic supplement that we think about. But I want to thank kind of everyone who's helped me throughout my path and my career, all my colleagues over at Columbia on the left. In this specific project, Harris Wang, 2 collaborators from Denmark, Mareike and Morten, and then Mike Groshon, who was one of my co-mentors. He was actually the father of like the gut brain that people refer to. And then also all of my colleagues here, and Dr. Brown for giving me the opportunity to speak here today. With that, I'll open it up to any questions.
Well, thank you very much, Dr. Cusimano. That was a very excellent presentation, very clear. We have exactly 1 minute. If anyone has any questions, please unmute yourself. If not, I thank everybody for attending Grand Rounds today. This concludes Grand Rounds for the academic year. We'll start back again in the fall with the State of the Department address. This was a great way to end. We wish Dr. Wong success in her future endeavors. She's always part of the family, and Dr. Cusimano, we're grateful we'll have you around for at least another year or more. So thank you, everybody. Have a great and safe day and have a good summer.